So, ladies and gentlemen, be seated, and we come to the 40th APAO Congress in conjunction with the 83rd AIOC in New Delhi. And in New Delhi, we have our own glamorous court martial in ophthalmology. So, court martial in ophthalmology started in 2010, and it would interest you to see the faces in 2010. Most of them are there, and we have Professor Ava Hussain, who is there right in the front. Madam, can you see your picture in 2010? 2010, you are part of the court martial at IRSI, and you are still there. So, ma'am, you have a very, very important. Ma'am, are you listening to me? You would listen to me, not to Dr. Chitra Ramamurthy, please. So, ma'am, you have a very important part to perform. Don't listen to her.
No,
the
please
part
listen to
that
me.
you have to perform is the part of the news.
No.
And all the way representing all APAO countries, you're here with us today to news those glamorous surgeons who are taking selfies, not paying enough attention to proceedings on the stage. So 2010 we started court martial in ophthalmology, and again we have
We had joy, we had fun, we had seasons in the sun. But the stars we could reach,
and we have
starfish on the beach. We had joy, we had fun,
we have this set of judges. Now this, unfortunately for me, this particular judge is a very unfavorable judge for the public prosecutor. But
No.
he is
You
a
be
very
that.
favorite judge
No.
of the young ladies on trial.
No.
That gives me a lot of sadness that I have to
you
have
remain
him
sad
as my
forever.
judge.
You stay sad forever.
Where is my other judge, the one with the turban? The one with the turban? The judge with the turban?
And all of you, please ask him to stop the video. I've been doing court martial with him for any number of years, but my photos are not there. He brings out videos before I was born.
So,
Prosecutor.
ladies and gentlemen, this is the 180th session of court martial in ophthalmology. And let us give a big hand to not only the surgeons who have given fantastic videos, and it is a fun and a learning session, but also the judges, and mostly to Dr. Chitra Ramamurthy, my good friend from my college days, who continuously bothers me with court martial proceedings. So with that, let us invite our supreme judges, Professor Ava Hussain. Professor Ava Hussain on the stage. Dr. D. Ramamurthy. And Dr. Mahipal Sisdev. So now Dr. D. Ramamurthy is a particular friend of mine and a particular judge who is friendly to the public prosecutor, because all that he cannot do at home, he does it in court martial. So thanks to Dr. D. Ramamurthy. Give him a big, big round of applause. And we now invite, and we have to invite this friend of mine who she insists you have to call me the angel. When in court martial you're announcing me, you have to call me the angel. So, well, she's an angel of treacherous culprits who pose as surgeons, but please give her a big round of applause. Dr. Chitra Ramamurthy, the one and only. And Chitra, you have to clap for this friend of yours. Nobody is going to clap for him, but at least you clap for me. So, for this session, My every sweetness, every iota of my sweetness is shelved. I'm going to be the rude, the hard, and the tasking public prosecutor, be it the beautiful ladies in the front row or be it Rakesh Saikya, dacoit of the Chambal. अभी से लटका देंगे. So we first call upon our honorable jury, please. And our honorable jury is Professor David Chang, Dr. Douglas Coe, Professor T.P. Lahane, sir. Sir, come on to the dais, sir. And Dr. Jignesh Taswala and Dr. Maddy, please come.
And Dr. Manipal will be joining soon. Can you keep one more chair there? Two more chairs.
Okay, we'll do that. दो चेयर चाहिए. By the way, the courtroom seems to be very unresponsive. So the courtroom shall rise and give a big round of applause for our judges and the jury. Everyone rise. Everyone rise. Thank you very much. With the permission of the court, shall I start the proceedings, sir?
Yes.
Thank you very much. So we first call upon Dr. Vaishali Vasavada.
Where is the bell? You want this?
So Dr. Vaishali, hand on your heart and in chaste Gujarati, we are going to all go to Ahmedabad very shortly after 2 years for your annual conference. Hand on your heart, you have to take your oath, please.
હું અહીંયા આ કોર્ટમાં પ્રણ લઉં છું કે હું જે કહીશ એ સત્ય જ કહીશ અને સત્ય સિવાય બીજું કંઈ નહીં કહું.
Wow, that's fine. Thank you very much. So Dr. Vaishali, shall we start the video?
Sir, is it going to play from there or?
We have it here also. Same, no?
Same.
Okay, fine. I'll play it.
Can I? Do I have control over it, sir? So here, I can put my laptop, sir.
No, it's fine. I think. Yeah, it's working. It's playing.
Perfect. So I'm talking about this 64-year-old gentleman scheduled for a right eye phaco with a trifocal toric, and our fellow is operating. I was watching, and everything seems to be going fine. And the nucleus rotates well. I want to show you these 3 chops, and keep noticing on the right side where the first chop was created. Every time the rotation happens, I do see some red space. And I said, okay, now let me see what's happening. Now, till now, everything was going okay. But suddenly, after 3 chops, the nucleus stopped rotating. And I thought I can manage. I mean, I'm a senior surgeon. I'm so experienced. So I try and I said, let me remove whatever is divided. It's still not rotating very well suddenly. So I start my fragment removal, and as you can see, with all the modern machinery, the control, the technique, everything is flowing seamlessly. The material is coming into the phaco tip. The chamber is very stable. Everything looks fine. There is nothing that I should be worried about. And I'm already thinking about my next case and then the coffee break and all that stuff. But I can see some difficulty in moving these nuclear pieces. So I thought, let me take what's right in front of me. And I'm sub-chopping it so that I make sure that I don't induce too much damage to the corneal endothelium with these large fragments. I want to break them into smaller fragments. And you can see that the removal is going on pretty much okay, except for the fact that every time I try to nudge the nucleus and rotate it, it isn't moving very well. But I don't still suspect anything. Now this is the point where I've removed half of the nucleus and now I'm seeing this clearing, but I'm still not very accepting because I think I can't do anything wrong. So I did the phaco and you will see what I do next. This is the last fragment. Again, everything looks absolutely fine. And I just yank out my phaco probe. And I think all of you have noticed that opening. I haven't noticed it yet. Now I'm doing a bimanual IA, at the end of which I then realize the PCR. Now the point I'm trying to make is every step has to be according to what it should be. So I stained, I did not find any vitreous, and therefore I continue with a bimanual IA which allows me to do a closed chamber technique and remove all the cortex. The nucleus was already out and I have noticed that PCR in that region, which is not very large, but I'm gently and slowly removing the cortex, not radially stripping, but doing a side-to-side swipe so that I don't enlarge the PCR or cause any drag to upward drag, although there is no vitreous. The other smart thing that I now do is I inject dispersive viscoelastic before I remove my IA probe, but I see that there is a little couple of those fragments in the anterior vitreous phase. Though the vitreous phase was intact, it is not in the anterior chamber. So under topical, at 3.5 millimeter, I am now injecting this trocar into the eye. And you can see that the chamber is still well formed. I keep my irrigation anteriorly, go through the pars plana and remove not only those fragments that were there, and I do an adequate anterior vitrectomy around the area of the PCR. And as you saw, this was scheduled for a trifocal toric IOL. Now I think you can all notice that PCR, but I am being very gentle and my second instrument is sort of ready so that in case the haptic, which was supposed to be in the same axis as the PCR, does not go through the PCR. So very gently and slowly I am implanting and unfolding this IOL. And you can see the purpose of putting on this marking was to show that the intended axis of the trifocal toric alignment is at the edge of the PCR. But you can see that there is no further vitreous disturbance. The PCR remained the size it was. It did not enlarge. I sutured the incision. Another very important thing, I think, even if it was a 2.4, this is what the patient looked like 1 week after surgery on slit lamp, but that's not enough. I have to document it with the visual acuity and other anatomic. You can see this is a snapshot from my EMR, 6 parts plano, N6 plano, and the abrometry shows top right green refraction and practically no refractive error. The macula looks fine at 1 month postoperative. So I think the take-home message is do not lose your calm. Use all your techniques, technology, and adjuncts, including triamcinolone, your vitrector, your dispersive viscoelastics. So limit the amount of damage. Everybody will cause damage one day or the other, but try and limit it. And pars plana vitrectomy for me, because I did not pull the vitreous upward, I drained it down. It allowed me to maintain that PCR in the periphery at the same size. It did not enlarge, and so I could put a trifocal toric lens in the capsular bag. Thank you.
Thank you.
Thank you very much, Dr. Vaishali Vasavada. May I begin my trial, Professor Ava Hussain and Dr.
Yes.
Ramamurthy, sir?
Who can begin it?
Dr. Vaishali Vasavada, that sentence about your top pearls is very, very appropriate. And look at Dr. Chitra Ramamurthy taking a snapshot of that pearl that you give to her. Do not lose your calm. Madam, please take a seat. So now my trial begins. Do not lose your calm, madam. Now, a fellow doing a surgery. It is that same dialogue I've been hearing over years and years. My fellow was doing a surgery, I was sipping coffee, I was seeing in the video, and then the fellow was not doing well, so I finished my coffee and then strolled into the OT. Madam, don't laugh.
Don't intimidate my defendant. I'm there.
This, I believe, is a human eye. So what were you doing sipping your coffee while your fellow was making all those mistakes?
No, sir, I wasn't.
Number one,
No, I don't
you will
think-
have chance
Don't
to
even answer him. You've done your job. I'll take care of it.
Top pearl, please maintain your calm. Sit down.
Calm.
So, the second thing, madam uses very modern machines. Yes. But, madam, you also have to realize all these modern machines have the names on the overlay of the surgeon as well. I could not see your fellow's name there. So I will believe that you possibly edited that and it is your own surgery, which the 40th surgery, the last surgery that you're doing, and you botched it up.
No, she's done so well.
Madam, maintain your calm, sit down. So actually it was a very juvenile direct chop that you did. I will not say your fellow, and even if it was your fellow, you are responsible for this case. You accept that?
No.
Yes, of course she
Of
accepts
course
it.
not. Vaishali, you should stay quiet. Don't let
Judge,
him.
Madam Judge,
Not a single
can
word
you
out of
can
turn.
you please ask Madam to maintain calm? Professor Ava Hussain, the judge, can you please bang your hammer?
Defense, please keep quiet.
Keep quiet.
When you-
Yes, keep
when
quiet.
your chance come, you talk.
Wonderful. Maintain your calm. So it was a very juvenile direct chop. Now the other thing that we have to allude to is the intraocular pressure. And in IA, you were doing it at 20 millimeters of mercury. Now, when you already have a rent, why should you not do a stripping of the amount of cortex that there is under visco, so that there's a tamponade with high molecular weight viscoelastic on the rent area, visco above, and gradually stripping out whatever remnants of the cortex there is. Why did you not do that? And you had the irrigation there. The irrigation itself can churn up the vitreous and can get the fragments down below. So you have to answer all these questions, madam. Now the main thing and the catch. Are you maintaining your calm? Sit
We're
down.
fine, we're fine.
Now here is a wonderful institute, one of the best in the world, and they have fellows do trifocal toric for their patients. Is it acceptable?
Objection, Your Honor.
So
Can
are
he
these all
overrule?
free patients that your fellows operate on and use trifocal toric? Do you have financial interest in these companies?
Objection, Your Honor. Could you please...
Trifocal
shall I-
toric by a fellow.
Objection overruled.
By a fellow. Maintain your calm. Sit down.
Public prosecutor.
Mind your language.
Now, everything said and done, this eye is going to have the test of time.
Stop
Why?
cursing my defendant, public prosecutor. I think I need a chance to defend my public prosecutor. I think he has spoken a continuous
Just a
monologue.
minute. Yeah.
I would
Doctor,
like to say
defense,
there's no
please,
end to your
please,
talking.
Please let me finish. 2 minutes. Maintain calm. She has already said so. So this is going to face the test of time, because in a patient like this, the next part of the treatment that was done was absolutely fine. The vitrectomy, the importance of having the base of the vitreous in proper order, no vitreous in the anterior chamber, everything was done accurately. However, a trifocal toric in such patients, decentration, tilt, rotation is possible. Again here, what you could have done is you could have prolapsed it over the anterior capsule, and that would have given a little more stability to a ruptured posterior capsule and a better centration.
Objection, Your Honor. I would like to intervene now. I think
Would you
he's
have
done-
something to say,
No, I
Dr.
think
Vishal?
I
Objection
would
sustained.
take. I would-
Objection sustained.
Yes. Now,
You
we
talk.
leave the juvenile chop. It is an error which can happen in anyone's hand. It's how the management, and I think all my wonderful judge and jury would understand that she has contained that extent of PCR with not a millimeter increase, and she has ensured she did the vitrectomy at the right time, the pars plana approach. The stripping of the cortex was so gentle. IOP being at 120 makes absolute sense. There was no urgency about it, and the way every single step was done. Yes, the decentration tilt, the rex's overlap was good, and we clearly see that the haptic of the toric IOL was subjacent to that area of rent, not exactly sitting on the rent, and with the rexus overlap, I do not see why there should be a rotation. Even in a normal scenario, the rotation is about less than 4%. And in this particular case, it cannot be any different from the routine. And I think we need to appreciate the gentleness and the astuteness of the surgeon at the time of a storm and how beautifully she handled it. I think I've said my bit.
Comments from the jury, please. Starting from the.
Fantastic job done, Dr. Vaishali. I am with the Defense Counsel. The way you have managed it, stayed calm and nice. It was very well managed. The way, I mean, the size of the PCR had not increased. That was the first point. If it had increased, you would not have been able to put it. So, full marks to you.
To be able to keep the size of the opening the way it was and put the lens in the bag, I'm quite confident that that lens will last a lifetime for this patient based on other patients I've seen. So I would offer my positive statement.
You know, I think that we certainly do worry about long-term what could happen to the lens, but when you have, it depends on the patient, you have to know your patient, but for many of them, if they don't get the premium lens that they were hoping for, it's a very bad outcome in their mind. And I think this is one situation where you can be aggressive and give them a chance at it, knowing that if it tilts or decenters, you can always remove it and replace it. But this is the only time she'll ever have an opportunity for a trifocal lens, and I think it does make sense to go ahead and give her that chance, knowing you could always switch to a monofocal later.
Actually, she did a fantastic job and managed it very well. And I do agree with Professor Chang that it might happen in the future for the stability of such a kind of premium lens, but we have the chance to change it later on. She gave a better chance for the patient primarily, then secondly, we can deal with it later on.
I think what she did is very good and excellent surgery. The PC tear has not increased at all. And when she implanted the IOL, so why not to give chance to the patient that he wants a premium IOL, and when there is no vitreous in the anterior chamber and small tear behind, and the vitreous is not going to displace the lens, what she did in the, I can say, multifocal is correct, and really appreciate what she did.
Judy, please give your final comments.
I think.
So a
well,
trifocal before
One
the
minute.
judge gives his
One
final
moment.
verdict.
One
a
moment.
trifocal
One moment.
toric-
Don't interfere. Yes.
A trifocal toric by a resident.
No. There's nothing that says that a resident can't use a trifocal toric. And anyway, I think the result was excellent. The final outcome was great. But certain things which could have been done better. You yourself said that you yanked the irrigation port off. I think at that point of time itself, I could see some fragments floating in the anterior vitreous and the PCA rent, and all along you are a little circumspect about the PCA, something being wrong. So I would have definitely injected a little more of viscoelastic and dispersive viscoelastic, not high molecular weight viscoelastic, as you said, public prosecutor. That's what needs to be injected in there. And that would have kept the tamponade at the PC rent quite adequately. And again, when you did the pars plana vitrectomy, I would have still injected transplanar state into the anterior chamber, because that would have ensured that your PP vitrectomy is quite complete and all the vitreous is drawn in. But I think there's nothing wrong in implanting a trifocal toric in a situation like this. Ultimately, it all worked out, and very often, as Jury Chang said, if you don't give the patient what he or she desires, they're not quite happy. Well done.
Sir, on the scientific aspect, getting
Reverse
it captured in the
capture.
anterior capsule,
Could be the next
would be-
step.
No,
If it was a
that's
larger
fine.
PCR.
No. Actually, she dealt it very well. The PC did not increase, which was actually a blessing. Otherwise, with a toric, it would have been really difficult to place it in the right toricity. But maybe anterior capture could have helped on the strength of the stability, basically.
You need to have a smaller rexus to manage that in that particular case.
No, I think
it
it's
was
a
average.
very valid point, Partha. I would agree with you. but this was a very peripheral rent, very
Yes.
confined rent.
Yes,
And
yes.
the lens, there was a good coverage of the
Yes, absolutely,
excess
very
margin.
well
So
covered. Absolutely very well covered.
The other factor is that if it does decenter late, you still have that anterior capsular rhexis to capture it.
Now I can do it.
guilty, not guilty.
Juris, please give your final comment, whether it is guilty or not guilty.
All of you have a
So
card.
wait.
Not guilty.
Dr. Douglas Cobb,
Sir, you'll have to lift it. NG is not guilty.
thank you.
Thank you so
This
much.
is not guilty.
Thank you.
Bata?
Come and get garland.
So your oath, Dr. Sheetal Brad, is going to be in Kannada or Punjabi?
Hindi.
Haji?
Hindi. My mother tongue is Hindi.
Get lost from Punjab then. So in Kannada, take your oath. Oh my God. इनको तो फांसी देना ही है.
से क्या मतलब?
Chalo, come on. Chalo, then in Bengali. Ami jaha bolibo. Repeat it after me.
Okay.
Ami
Ami
jaha
Jaha
bolibo.
Bolibo
Shotto
Shokto
bolibo.
Bolibo
Shotto
Shokto
chhara
Chara
কিছুই বলিব না.
কিছুই বলিব না।
Wonderful. So shall we begin?
Yes, sir. They need to play the video.
Yes, let's play.
No, can you please go back to the
Yeah.
title slide?
Surely.
I cannot see the video here.
No, video is there. I'll play again. Wait a minute. Fine?
Yes.
Okay. So I think everyone knows that a lot has happened. No, I think I'll have to
Once more?
start it. Yes, sir. Let them not start the case. I'll just give the introduction.
Yeah.
So a lot has happened in my life since the past 1 year. I have moved cities. I have moved from Bangalore to Chandigarh. So a lot of weather change. I changed jobs. I started my new practice, so a lot of stress. So all this has recently caused a lot of dry eye and stress-induced and
Why
and
should you
all.
apologize?
Yeah.
You did
No.
very
I'm telling you because
You plead guilty.
no, I do
way.
not plead
Don't
guilty.
have to be. It's a well
So
done case.
basically, yes, so this was one of the cases I recently did. So this was seemingly a normal case, 55-year-old male, grade 1 to 2 cataract, and this was planned for fine vision trifocal toric lens, plus 23 with plus 2.25 cylinder. Target axis was 13 degrees. So the surgery goes on like this. So you can start, please. Please play the video.
Yeah, explain.
So as you can see, I've made my wound and I have stained the capsule. And I've tried to make a 5 to 5.5 central rhexis. So rhexis looks good. And this is followed by a gentle hydrodissection. And as I'm trying to chop the nucleus, somehow I had this sudden dry eye and focusing issue, and I was not really able to see where my chopper is going, and inadvertently, I create this iatrogenic CCC tear. So I take the full responsibility. This is not my fellow's case. This is my own case, and this happened in my hands. But the thing is that I realized it pretty immediately, and I started taking my precautionary measures. So of course you cannot see the parameters here, but I have reduced the bottle height. I have reduced the vacuum to 250 millimeters of mercury. I have also reduced the flow rate to 22, and very gently I have been able to remove the fragments. So this was a softer cataract. And now you can probably see the anterior capsular tear quite clearly. And this was followed by careful irrigation and aspiration, especially in the area of the tear. So as you can see, I'm doing side-by-side movements to gently pull that nucleus, pull that cortex out. And towards the end, I'm also using OVD, copious amount of OVD, to maintain the chamber. And here actually my flow rate is very low, just ensuring that the tear does not increase. And at the end also, I maintain the chamber with OVD. Now the question was that should I go ahead with my trifocal toric lens as planned or not? So I decided to go ahead with it because the lens which I'm using here is the fine vision trifocal, and interestingly the target axis was also in the area of the anterior capsular tear, but this lens having a special design, which is the pod design or the double C loop design, is thought to be more stable in the bag. So I have gently implanted the lens, and you can see that around the tear it has the two haptics, which are probably, it's not causing too much pressure on that area because of this special design. And you can also gently rotate this lens because rotation of this lens is possible in both the directions, clockwise as well as anti-clockwise. And you can see that the lens is now in the intended axis, which was 13 degrees. And looks fairly stable. So I'm not going ahead with irrigation and aspiration because I do not want to increase the size of the tear. And you can see that the flap motility sign is positive till the end of the case, which shows that there is no posterior extension of the tear and there is no PCR. And the case went quite well. So on first day post-op, this was the result. You can see the tear, but also the lens, which is very stable in the capsular bag. And this is the autoref reading, just a 0.75 cylinder, which probably was due to the corneal wound edema, which was seen on the first day. Patient's vision was 6/6 partial, and you can see a very stable lens in its intended position. So thank you so much for your kind attention.
Thank you very much. So, Dr. Sheetal Brar, can you treat your dry eye first?
Yes.
Can you treat your stress problems first? Please come to Kolkata. We will treat them for you. Then you can go back to Amritsar.
Sure, sir.
Right? Okay, so shall we begin the trial, ladies and gentlemen, jury? And so, here we are. The queen of refractive surgery. Yes or no? Yes or no?
We don't encourage you at all. We are not with you.
Okay. Now my question to the audience. How many of you, if you have cataracts, will go to the queen of refractive surgery?
Raise your hands, be on our side.
Are they?
I can see a lot of hands here. In my
3
support.
hands, and they have fallen for you, Dr. Sheetal Brar. So this is what a trainee in cataract surgery does. Okay?
Objection, Your Honor. She
charges
remarks.
1.5 lakhs and high-end trifocal toric. Now, when you look at the technique with which she has followed, even a trainee is supposed to follow the right techniques. She takes out the irrigation aspiration, no support of visco when you're taking it out. Obviously, there are chances that it can extend.
It was a 4-minute video. You can't show everything.
She has shown that she has not placed viscoelastic before taking it out. Yes?
No,
Stay calm.
you should stay calm.
And Madam has a 6 crore Visumax 800. Yes, Madam?
I have, but you cannot use it for markerless.
Ah, you have a 6 crore, but you cannot use it for a marker. Such a nice statement. So why don't you spend a few lakhs on a markerless system and give benefits to your patient? It is not acceptable with your practice, with your stature, that you do not use a markerless situation for your patients.
You need to also
With
talk
again
like,
a capsular tear, you place a trifocal toric. Yes, we have discussed in the previous case. Again, a trifocal toric. Now, did you tell your Punjabi patient that your trifocal toric might shift, might have a tilt, might have a decentration, and you were stressed, you have dry eye? Have you told this to your Punjabi patient?
objection, Your Honor. Objection.
Yes or no?
He is
Yes or no? Have you told or not?
intimidating my defendant, who was too honest, to a very cruel public prosecutor. So please let me take on at this time. So my contention is, this was the care taken in surgery, keeping a stable anterior chamber. Did you see that she even removed the cortex from the area of rhexis extension as the last step? Very careful control parameters. The important thing here, she was sure with that fine vision lens of hers. Company guys to note, I need free lenses. So it can rotate clockwise and anti-clockwise. It has a rounded edge. It has ridges on its haptics. So,
Yeah.
it all augurs for stability.
What is your financial disclosure?
No financial disclosure. So if you can optimally
Neither
position
mine.
some of these lenses, especially this kind of lens, would stay. And she has also tucked it in so meticulously, like she has aligned this other haptic before leading haptic and finally tucked this in. It has rounded edges, so it's not going to extend the tear, and she was conscious that the tear did not extend at all. What are we discussing here? It's an absolute no-brainer that this IOL will sit
Okay,
where
can
it
we have the
sits.
comments of the jury from the other side, please?
Scientific comments, please.
You can
Yeah.
start.
Your comments.
Actually, she did a fantastic job. I think with this kind of extension, as long as we have a stable IOL intraoperatively, there's a less chance to rotate or to get tilt later on.
Here again a scientific question. Since it has extended in
Martha,
one
can
side,
all the jury finish their comments and then?
right?
Dr. David.
So when you have a single radial anterior capsular tear, how to avoid it wrapping around? You want to avoid rotating anything large in the bag because then it puts counter pressure on the capsule. So one comment was, once that happened, you kind of want to chop the nucleus and then bring the two halves into the anterior chamber so that you did have to rotate it, but you got away with it, so that was good. But just a tip is bring things into the anterior chamber, so you just want to avoid rotation. So likewise, with that lens, you have to be very careful with a toric. If you're going to have to rotate it, it's often with the rotation that's when you get the wraparound. So if you're not sure if you can open it and avoid rotation, maybe if it's a low power toric, maybe do a astigmatic keratotomy with a spherical multifocal.
I think what she did, there was an anti-capsularity.
Sir, election हो गया अभी. Voting सब खत्म हो गया.
No, that is
नहीं
not
सर,
like
आप
that.
तो
But
सच बोल रहे हैं सर, आप हर समय सच बोलते हैं.
scientifically, I think what she did, Partha, was a way. I think she has implanted the lens, toric lens also, an anti-capsular tear. If it is there, that will definitely not rotate the lens. So what she did is correct, and I think she did an excellent job. It is not because of dry eye. She might be nervous for that she told you, but she should not have. Thank you.
The case turned out very well. Three things, repeating what was said in a way. When you see a radial tear, don't rotate the nucleus away from it. You can rotate toward it. You can lift it up, but always rotate toward the tear. when you brought the phaco tip out, you didn't put the OVD in right away. And the third thing is, even if you have to rotate the IOL, instead of simply trying to rotate it, flex it away from the area of the tear and then do your rotation so that you don't have the haptics dragging along the capsule.
Well managed case, I would say कि at your level, the way we have done it, it's perfect. I feel, in spite of what the other jury members are saying, I feel with the stability of the lens and all, the last final steps you managed was very good.
Thank you, sir.
Maybe we could have the judges sitting together, I think, no? Remove one seat.
Speak it.
Well, I think the points have already been said. You were lucky to get away with not extending it. That's the only thing. Partha was right in saying the first time around you didn't put viscoelastic when you took out your handpiece. This could have extended better to bring it out into the capsular bag or above the capsular bag and then do it. The only question would be long term, because there at the rib there could be a toothpaste like a effect, like a zipper effect, and then it could get decentered. That's the only thing that why, because you just shown immediate post-op, right? So let's see what happens a couple of years down the line or a couple of months down the
It
line.
will fibrose by then.
Yeah, but it will fibrose irregularly.
That
The
is
point
exactly,
is because there is an
that is a very
extension.
important point. The fibrosis with later years will be irregular, and that's a scientific point. This is different from the case scenario that Vishali gave, which was a posterior capsular tear and it's in the bag. That lens is not going to rotate. But this one with fibrosis can be a tilt, and especially because it is only a one-sided
The
tear.
point is that and angle of contact is much better in this particular lens.
No.
Yeah,
We are
so
talking
then
about
it is more
centration
stable.
and
Hence,
Not selling. Not bad.
she's an established KOL of that lens company. She didn't make the financial disclosure, but for any lens where you have a rip in the interior capsule, what is it? See, when they fuse together, they can push it to a side and then the
Yes.
it doesn't become central.
They all said about the first thing you should have done. I think the first thing you should have done is to put lubricating drops in your eyes.
No, the judge cannot afford to be mean.
Applause,
at all.
applause,
That
applause.
is meanness. You guys cannot be mean to a very
she-
simple
she-
defendant
she-
of mine.
No, it was not. Please don't have it. This is not home.
stay calm. Stay calm. Stay calm. Sit down. Sit down.
So,
I'd like to ask, do
No,
you
you-
recommend...
You please go to the court and see how mean the judges are.
no, this was her comment. This was her confession. She said, I had dry eyes, I was seeing blood.
Stress.
When you are seeing blood, and how can you take a sharp chopper there right at the capsule? I think this was absolutely iatrogenic.
Objection,
What
Your
did-
Honor.
No.
The other
I have the honor here.
Dr. Awad, it's a woman's world also. Please.
So I have
This
a
is
question.
getting different now.
One second, let me finish. So I think initially this was an absolutely avoidable complication if only you lubricate your eyes, and after having done the damage you have managed it quite adequately. And my genuine question is, because this lens is a little different from the other lenses, that is, it has this 4 haptic design and it is also has those ridges, they appear to be roughened up. Will the stability of this lens be a little better than the conventional single piece lenses that we are more often used to?
That's what is the promise is given. So
Because it's a...
Hear it from the-
I have a question for Dr. Ramamurthy. Would you recommend that she put in Viscoat, Provisc, or Helon 5 in her eye?
Sheetal, you really asked for
I
it.
think she should have punctal plugs.
No, I think, the
Dr. Abba?
valid question, valid answer is here because it is a 4-pod lens.
Yes, sir.
So, the stretch on the capsule is also a little more than the conventional C. The conventional C would be a more compatible lens in a capsular tear. And we are thinking about the shift which can come with the capsular fibrosis.
Sir, the conventional C lens has the haptics are longer, sir. The haptics are, the overall size is 13 millimeters and the haptics are longer. But in this
more
lens,
pliable.
the overall size is 11. And so the overall size is actually shorter So, and the edges are rounded. So it's theoretically, it may not cause that much
And
stretch.
better stability is there, larger contact surface.
I think the judge.
What
The
is
lens itself is
comment of the
smaller.
jury? Final comment. Whether you think that she is guilty or not guilty. Please.
Don't look at her note.
Dr. Jignesh sir, you please look straight out.
No, he's fine.
Yeah, wow.
Only,
So we have guilty.
no, only 2 guilty and all not guilty.
Again, please, let me see.
No, there were only 2 of them.
So
2. Sheetal,
Guilty
point note.
because I accepted in the very beginning that it was
Now you don't
an
have to
iatrogenic.
worsen the damage. You stay quiet.
See, your acceptance would get you a consumer court verdict against you that you knew you had dry eye. This is
Yeah.
willful
So-
negligence.
so please
This
be
is willful
quiet.
negligence.
Yes.
Okay.
You don't have to prove anything. This is willful negligence. You knew and still you did.
Okay,
You say,
thank
I took a bottle
Hey.
of alcohol. I knew I was drunk and I went and did surgery.
I am giving the
Now,
Fine.
can you garland Sheetal for... so
at
we
least
want
one
to-
nose has to go.
No way. Come Sheetal.
she is not guilty as
Yes.
because majority has said that she
Yeah.
is not guilty. So
you.
rather than giving punishment, she is appreciated.
Yes.
Dr.
Yes.
Dr.
Patient's
Coke has
outcome was good
specifically
at the
requested that
end.
he wants to garland her.
You come here.
So, Dr. Priya Narang,
Good afternoon.
good afternoon, madam. So your oath, and before she speaks his oath, she has said that whatever it is, she be garlanded or hanged. It has to be David Chang.
No. She never said anything like that. And please.
So, hand on your heart in Gujarati.
હું જે પણ કહીશ સાચું કહીશ સત્યના ની અલાવા બીજું કાંઈ નહીં કહું.
Okay. Shall we begin, Dr. Priya?
Yes, sir. So this is the case that I'm trying to show you today when the pupil snaps. So this is phacoemulsification which is going on. It's a routine phacoemulsification. Nothing was so special about this case when it actually started with. So you can just see this after the capsulorhexis, hydrodissection is being done. And then, if you can appreciate, there is a pupil snap happening at one quadrant where there is a marker. So now, this is actually an ominous sign when you have it when you're doing a phacoemulsification because you know that you have created somewhere down, there is a posterior capsule rent. So anyway, phacoemulsification is being done and then gradually irrigation aspiration was also being done. Now, just because I felt that yes, something is actually not right out there and maybe there's no frank vitreous, but actually I should be taking up a 3-piece intraocular lens for this patient. And so 3-piece intraocular lens was taken and it was dialed into the sulcus. So this intraocular lens, it looked quite stable at this point of time. So decide to do an irrigation aspiration and close up the case, but then, there is a rent and a small fragment also that prolapses into the anterior chamber. Now this is where a 3-piece intraocular lens actually becomes quite helpful to have there because you can actually place it in sulcus. And now what you see is actually that's a big rent out there and things are not so clearly visible. So iris hooks are taken, iris hooks are placed into position, and trying to see if this intraocular lens can be dialed and placed onto the margin of the capsular rhexis, but there is a decentration which is happening to this intraocular lens. So at this point, it was decided that yes, we definitely need to go ahead and do a vitrectomy because you cannot just leave this patient just like that. So what was actually decided was that take up a pars plana kind of a thing because limbal vitrectomy would not work very well for this patient, and especially in the quadrant where there is the frank vitreous prolapse occurring. So this is the pars plana vitrectomy which is being done, and you're trying to clear out all the vitreous and the strands which are present there into the pupillary thing, and the intraocular lens looks quite stable. And this was the intraoperative, the post-operative image of this patient in the post-operative follow-up, and this patient did quite well. So the take-home message is that, you should recognize when the pupil snap occurs, lower down the parameters, place a 3-piece IOL, do pars plana for the vitreous bulge. Thank you so much.
Thank you very much. Shall we start the trial, please? So take home pearls once again. So once a pupil snap sign is detected, you need to slow down on the motion of the phaco and again the irrigation aspiration under visco. So you have a snap sign, you know that it has occurred, and in such a case, that rent, in your case, at least gave you an opportunity and a chance that nothing went stretched before you took out nearly the whole of the nucleus. You were lucky, God was great. But it could have occurred at any stage and the whole nucleus would have fallen into the vitreous. Yes or no? Yes or no?
Scientifically speaking,
yes or no?
Scientifically
yes.
speaking, there is
yes.
a possibility of having
yes.
a drop nucleus.
Yes. So you, as a senior surgeon, you are not cautious enough, not correct enough, not appropriate enough for that situation. So what you should have done is just made it an SICS, taken out the whole of the nucleus, and then do whatever was required.
No.
Wait
Objection.
a minute.
No.
You will get your
worry.
chance.
Defendant.
You will get your chance.
I'll deal with him.
Okay, fine. You continued with phaco, right? Again, as I said, God was great. In the IA that you did, definitely has to be under viscoelastic cover. You did a very vigorous IA, and the PCR absolutely expanded as it would be possible. It expanded, it went on to become a very big PCR.
Objection,
Next,
Your Honor.
no objection, nothing, let me finish. You did not use triamcinolone for the vitrectomy. Third thing is, there was that small fragment at the end. You still wanted to grab that fragment when you knew that the tear had extended and vitreous was already there. So grabbing that fragment along with the vitreous, you're pulling out on the vitreous base.
Objection.
You are guilty.
Objection.
Yes or no?
Objection, Your Honor. Just allow me. Now, pupillary snap sign, she had the intelligence to check it, and she has done a supracapsular phacoemulsification, which is clear that she has not done in the back, and there was no obvious PCR. She even showed us that.
What does the snap sign say?
It indicates that there is a PC opening.
Yes, it is a
Yes.
PCR.
Yeah, but there was no evidence, no, in the pupillary.
What evidence? Snap sign is an evidence.
You can see the followability, the ease with which she could
Take
remove
off.
the cortex are all indicators that the vitreous has not been disturbed. Even with a frank PCR, if the vitreous is not disturbed, you remove the cortex. And then when the moment she realized that there's the PCR, it happened. When it happened, she immediately put the iris hooks, gave visibility. Okay, she could have let that epinucleus float into and go to the retina surgeon. In that reflex moment, she has taken it off. That's all. She anyways knew she had to do a vitrectomy, which she did. And she did a pars plana vitrectomy. So the size of the PCR did not increase. It remained stable. And she had anyways placed a 3-piece lens. It sort of prepared that pupillary snap is omnious. It's not that she was blind to it. So I think you are guilty for questioning her for nothing.
Oh. Judy.
Yeah,
Yes,
Yeah.
Dr. Chan.
Yep. You know, the pupil snap sign it can be very subtle, so a lot of times you don't see it. But since you did see it, it's very ominous because it means you may have blown out the posterior capsule, and anything you do, you could push, especially with the hydrostatic pressure of the irrigation fluid, push the lens back down. So I think that number one, that would be the time to open up the pupil to both see with iris retractors to see what's going on, and if necessary, levitate the nucleus forward. And I think that is a situation to strongly consider converting, because you're just blind to how big that rent is, and the more you push and rotate and so forth, it can expand, and then everything will
She
drop
has
down.
done a
No,
supracapsular
wait
phaco.
a minute. No, let all the jury
Yeah, yeah.
give their comments.
Yeah.
The scientific comments. These
Yeah.
are very important for
Yeah.
every one of us.
Right.
Yeah,
Professor
I think that the most important point that she noticed this snap sign. This means that a mental flow chart has been prepared how to deal with this case, and this is the success how to manage this case. If you miss this sign, you might end up with falling down posteriorly completely beforehand. And she did a fantastic job, and because she noticed this snap sign, she succeeded to complete the case with slow fluidics, and at the end to correct the lens decentration later on. And the most important part that she did is that she did anterior vitrectomy pars plana, just to truncate the vitreous in order not to allow for more vitreous and more decentration, and to violate the old capsule later on.
Professor Lahane, sir.
I think I agree with that, what they said. Only thing is that when she was knowing the snap sign, the extension of the tear might have avoided by going slow. You can say for the phaco also you should go slow. Also the aspiration should also go slow. And if you are having snap sign, lastly you have dilated the pupil by the, can say, use the hooks. So before that only you should dilate and see can you find the tear, and that might help you more. Yes, thank you. But you did an excellent thing.
Professor Ko.
I think it's amazing you actually saw the snap sign, because it's very subtle, and you're looking at the phaco tip working in a different area, and to detect that is impressive. But I would have loved to have stopped then and seen if I could determine where the tear was, and do everything I could to keep nuclear material away from it, and just really slow down my fluidics all the way through.
Taswal.
Yeah. The caution had always there. Once the snap sign had occurred, that a PCR is there. What you have done is the supracapsular phaco, that is good, but as they said that fluidics have to be low. And after that also, once you removed it, you are changing a fragment just near the opening that helped expand the PCR. So that was another point which had to be taken care of.
No way.
And one second, ma'am. And in spite of all this, of course, the right thing you did was the right lens that you have chosen. You dialed it properly and did a vitrectomy later. You should have used triamcinolone also in between to see how much of vitreous had propped up into the capsule area. So these are the points which I'd like to tell.
Well, I think most of the points have been covered. It was, you got away with it. It was an aggressive approach. That's about it. But obviously when you are under stress, you kind of miss certain things. But you are also a proponent of the scaffold technique, I suppose. So,
Yeah.
and in any case, if you would have fallen, she would have done the glued IOL.
And I have a specific question to you, Dr. Chang. In the sense, you are a great proponent of these three-piece lenses in the bag and creating an optic capture. So, do you think, I mean, even in a situation where we have a like this, you could have that would have stabilized the bag a little better, because the capsular excess margin was still intact. It was only the PCR that had occurred.
Yeah, particularly with the monofocal, putting
because
it
she had a
in the
three-piece lens inside.
Yeah, putting in the sulcus and then optic capture would be very, very safe, in terms of that.
Three-piece lens in the sulcus she put in, sir.
Yes, on the sulcus,
she put it in
she
the
could have done
sulcus.
an optic
Yeah,
capture.
And
that's
optic
why
capture
I'm saying
with the
she could have
anti-capture.
easily done an optic capture.
With the anti-capture.
Did you do an optic capture?
No, not exactly.
Not exactly. What is exact about it?
The exact was that the patient was very fine,
Very
the IOL
fine.
was well centered,
Six
everything was
vision,
okay.
six
Yeah.
vision.
Take home is that if you have a
You can do
three-piece
one
lens
optic
right there, your rexis is just about 5 millimeters, you have a 6 millimeter optic.
No, you didn't see clearly. There was a
Ah,
rexis.
There was
The
a-
judge
The
didn't see clearly.
rexis was there was a small
Small
extension
area
of the
where there was
rexis,
extension.
and when I was dialing the intraocular lens, I had placed the haptics in a way that it does not go into the area where there is the deficient part of the
extension.
rexis.
Yeah.
So that is one thing which everybody missed.
No, I saw.
So in those cases, then it
Optic
becomes
capture.
yes.
Yeah. So, Dr. Ramurthy, dry eye for you?
Sorry?
Dry eye?
I think we'll hang the public prosecutor in this case, make an exception to the rule.
So, Dr. David Chang is going to present the news.
No, 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 no.
Guilty, not guilty.
Guilty?
Guilty, not guilty. No,
No,
Gaswala, you
Dr.
not
Priya is
guilty.
very sporting.
No,
she
she's
would
not
love to
sporting.
take the news.
I'm not sporting, not guilty. Yes, not guilty. Many more not guilty. The judges, I request you, not guilty. You have to, it's not guilty. Thank you very much.
I think, Dr. Barta, what saves this case is that the vitreous is well formed. It's not a fluid vitreous. If this is a high myope with fluid vitreous, you might end up with falling the vitreous.
So, Dr. Harshul Tak.
Dr. Ramurthy
Sir.
he has to go for a symposium.
Dr. Ramamurthy. Court martial you, sir. You are the judge in court martial.
Now, what you can do is,
Yes.
you can hang him.
Stay back, sir. Stay back. Stay back. वो symposium बाद में जाना sir. Symposium बाद में जाना, please. बाद में जाना sir.
अरे
Stay back. Stay back. So, Harshul, yes.
Sir.
Judges
In
can
Rajasthan.
recuse themselves from उसका रिश्तेदार आ गया ना तो इसलिए
In
मैं-
Rajasthan. Your oath.
So, honorable jury and judges,
ये
मैं
राजस्थानी
जो
है
कुछ भी
क्या?
कहूँ लो, मैं जो कुछ भी दिखाऊं लो, जो कुछ भी कहूँ लो, साची साची दिखाऊं लो, सच के सिवा कुछ नहीं दिखाऊं लो.
और कहना भी है सच, ये तो बोलो.
Yeah,
या क्या?
I
हाँ,
said,
तो बोलो.
I said yes.
So, shall we start?
Yeah, thank you so much. So this is the case. The other eye had already been implanted with the toric IOL, and this other eye was also planned for toric IOL, and this was a 16 diopter of toric IOL with 1.5 diopter of corneal astigmatism. So I go ahead and mark the desired axis here, where the toric IOL was intended to be implanted. And a slight posterior polar element was also there, but it was majorly a posterior subcapsular cataract. So I go ahead and put Phenocaine plus, this is under topical anesthesia, put OVD, and make a main port incision. And this is my standard 1.8 millimeter phaco incision, which I make. So it was just proceeding as a routine case, and there's a capsular axis. We all know that the sizing has to be good to place toric IOL or multifocal IOLs. So the perfect size of the capsulorhexis was attempted. Can I have a control? I can forward it, you know. If I have control, yeah.
You will
So,
not have control. You want to come here? Ajay.
yeah, right. Yes, yes. So this is the hydrodissection cannula. So I just go ahead and do very gentle hydrodissection there. And once I have this hydrodissection, what happened? No, no, no. Yeah, yeah. Okay, so this is the phaco which I complete. So it was just proceeding as a normal routine case, and I just go ahead and put some visco before and suddenly see what happens. So my assistant handed me over a visco cannula which is not tightly fit on the syringe, and there is a rupture. And now at this stage, because of this cortical matter, I can't make out that what is the extent of the tear and what all damage has been done, but because of the fluid movements, I can make out that yes, there is a vitreous disturbance and there is a PCR. So I go ahead and do first do limbal vitrectomy. It's important to clear off the vitreous before I can make out that what is the extent of the tear. So I go ahead and do vitrectomy and on cut IA mode, maintaining closed chamber and staining also with triamcinolone. And after doing vitrectomy, I use the vitrector to take off the entire cortical matter. So at this stage, it's important to maintain closed chamber and never let your chamber collapse. So whatever damage is done, it's fine, but you need to salvage from that point. So I again go ahead and put some OVD before changing my hands. Change my hands, and so now I've cleared off the entire cortical matter, and at the same time I'm just thinking that what can be done now with this extent of the tear. So I'm maintaining chamber, and so the posterior capsule was torn in this area and anterior capsule is also torn here. So that's what I realized, that it's now not possible to place the same the toric IOL in capsular bag because there is no, and the direction of the haptic was also in the same area where the anterior capsule is also torn and posterior capsule is torn. So I decided to defer the surgery because there was no 3-piece IOL available of like 16 diopter at that time. Routine powers we do have and backup from 18 to 23, 24 3-piece lenses, but that's what I decided to defer the surgery after 1 or 2 days. And for in the next setting, we explained to the patient that yes, we'll put a 3-piece IOL and I'll do a surface ablation 1.5 to 2 months later. So this is after 2 days. I just opened up the same incision and enlarge incision a little bit and put a 3-piece IOL there. So I'm very careful that the leading haptic nicely goes. So always keep it horizontal below the iris so that you don't have tilting or the haptic doing further damage. So I go ahead and put this lens in the sulcus and put some Miochol and finishes the case. I'm maintaining the chamber again, doing hydro stitch of all the incisions, and this finishes the case. So 1.5, 2 months later, we did surface ablation to remove the whatever corneal astigmatism was there. Thank you very much.
So, this is our ace surgeon who gets awards at ACRS, ESCRS. His videos, he showcases with the best of the symposia in ESCRS, Bob Osher Symposia. And he uses this word, I still don't know, iatrogenic. What was that? Iatrogenic is what you used. Is it supposed to be iatrogenic?
Yeah, it's iatrogenic.
Ah, that means you plead guilty?
No. That must be the mistake of...
You said iatrogenic,
Typing
you
error.
misspelled it, you accept it as iatrogenic,
you know,
and you
Harsha,
don't plead guilty.
He had nothing else, no fault to find, so he goes after the spelling mistakes.
Okay, now, yes, I have faults to find, madam. Please stay cool. Dr. Vaishali, you can please remind her. So in a PPC, why remove the irrigation without a visco cover? Dr. Harshul, this is a mistake. And this is something that cannot be taught to our juniors or to our colleagues. PCR can occur. PCR did occur.
For a
It was
different
PPC. It was a PPC. And you knew that a PPC would be coming. There could be a possibility of a PCR. And it did occur. You forcefully injected visco from the main port, and in the event you enlarged that PCR. So you could have injected from the side port very gently so that the PCR was just tamponaded and not overfilled, and it could have actually not enlarged. Again, why did you not do the aspiration of the cortex under visco? Again, I think a stable anterior chamber is much more important without flutter as well as without hydration of the anterior vitreous. Again, why leave the IOL to another day? You said that a particular lens was not available. How is it that you take up a PPC case without having a 3-piece lens in your OT? It is a backup lens for every PPC case.
Non-surgeons of Harshul's
Stay
caliber.
cool. Stay cool. Harshul's standard. He's showing off his standard. That's the standard he is. Sit down.
He just had a loose cannula given to him which caused the
And
PCR.
obviously when you take up on the second day, you would have nicely explained, फिर से दोबारा पैसा देना पड़ेगा.
What nonsense.
Sir,
And your toric IOL was at 80 degrees.
It was not a toric IOL.
Just a minute.
3-piece. You have
Just a
not
minute.
seen
No,
the video
please.
properly.
No, Chitra, I'm talking sense now. Now, the toric IOL, the toricity was at 80 degrees Harshul. You could have still placed a toric IOL in the sulcus at 80 degrees and captured it posteriorly over the rexus. Or you could have actually placed it in the bag as well. It is possible because your rupture was not end-to-end either. So you could have attempted, and especially, okay, I do accept it's a more stable environment on another day. At that point of time, you could have attempted a 3-piece lens in a stable anterior chamber.
It was
in the
1/3 of
capsule.
PCR.
Okay, now
large
let's
area.
have our.
ma'am,
Judy,
sir,
He doesn't want
can I
defense
just
counsel.
reply? Can I
No,
just...
no, I am there to deal with it. Only thing there's shortage of time, but it's a large PCR, so that I
Okay,
don't
fine.
think he could have
No,
done that.
I think,
Yes.
we just will have to have 2 or 3 jury, please.
Yeah.
David, please.
Yeah. Dr. David, yes, sir.
All the science associated with this.
Yeah.
Yeah. So one tip, I mean, this is something if you operate enough, it's pretty much going to happen sooner or later. And what I do is I take my left index finger and I always put it at the hub of the needle if I'm using 2 hands, because then I have 2-point fixation. And sure enough, there have been times when I suddenly feel something and you stop injecting. So it's just the faster, it's like a brainstem circuit, rather than, oh, I saw something move, I stop injecting then. So just put your index finger on the hub of the viscoelastic cannula and that will help. That being said, you displayed remarkable calm, because of course we're just so angry when this happens, and it's so, we're so distraught. So kudos for, you know, maintaining your cool under pressure there. And, you know, it isn't the end of the world. It's just, and you did a good cleanup. And then, you know, I do agree that in this day and age, I know with single piece acrylics, I've heard other people that don't have a 3-piece, and I really do think it's good as a backup, not only for these situations, but also severe zonulopathy. As many of you know, I like to put a 3-piece in the sulcus.
Okay.
Professor
First,
Ko?
Douglas, please give your comment.
Yeah, kind of related to what David says. Every time the technician, hands me a syringe, I automatically just do a little twist to test that it's tight. It's just become automatic, so that it's never happened to me, because it just becomes just as much as part of holding the syringe to grab it and do that little twist. And also using Luer lock syringes makes a huge difference in these kind of cases. To me, the rest of it, yeah, I agree, through the OVD, through the main wound, that could have been handled better. I think you could have put a toric in, but you can't argue with being safe and putting something in the sulcus in a situation like this. And actually, when you have that small of an anterior tear, you actually can do an posterior optic capture for additional stability of the IOL, because you have enough wraparound, because you have a very nice rexus size.
Professor Madi, would you like to?
Yeah. I think
Just a quick comment, please.
for everything I got from the assistant, I should screw it again and be sure that nothing will be dislodged later on. And here we have two ruptures, anterior and posterior here. And I think the best that he did is to insert the lens away from the stairs.
So Professor Avar was saying you have no choice but to hang him.
No.
What are you doing? You didn't even give me a chance to talk and you can't hang him.
No.
Please,
no.
The end result has been
Please
good.
give your
No, you
whether
can't do
it is
this.
guilty or not.
No, guilty or not guilty.
Okay.
Not guilty. Get him hanging.
Thank you so much, sir. Thank you so much.
Let's go. बाप रे, सीटी मार फॉर चंबल का डाकू, आ जाओ, शहीद हो जाओ.
I shorten it. We have only 10 minutes.
Yeah. No, man.
No. 1:15 the session starts. We are already in that break. Break time.
1:15 the next session.
1:15. Partha, 1:15 I have 2 sessions.
Forget it. So Rakesh, quickly, hand on your heart in Hindi.
Okay. So मैं जो कहूँगा सच कहूँगा, मैं कभी झूठ बोलता ही नहीं हूँ, चंबल का हूँ, डरता नहीं हूँ, जो भी कहूँगा सच कहूँगा, मैं सबकी कसम खा के कहता हूँ, मैं सच ही कहूँगा.
Okay, Rakesh.
So this is the actually subluxated cataract, and actually it's more than 6 o'clock hour. So and they are the some actually they are the one angle recession. The IOP is slightly raised in this case. So I make a port temporal side. So you can see the slightly the subluxation more. So after that we put the actually with the help of the cystitome we started the rexis and completed with the help of rexis, atrata forceps. So the rexis was circular, slightly bigger, and during the hydrodissection you can actually the vitreous was prolapse. So by this reason I do the vitrectomy, and after that we actually make one small tunnel, scleral ported for the Sioni ring, and then make 3 ports for the stabilize the nucleus with the capsule with the help of the capsular hook. Then I try to actually hide it again, but the British was collapsed again. So after that we decided to do the phacoemulsification by the stop and chop technique. During the phacoemulsification, during the small British balls also coming out from this port. You can see it in the side port, you can see the some British collapse. So after that we just remove the cortex. When I release the capsular bag, the whole bag is shifted toward the nasally. So I do the vitrectomy and then reposition the vitreous again and do the vitrectomy and put the visco, and then decided to put the Sioni ring in this case. But when I putting the Sioni ring, if I first go into the angle, then it goes in the vitreous cavity. So after try to remove in the 5 to 7 times, so I actually the vitreous, this will go into the vitreous cavity, and I try to remove it again, and then put the capsular hook again, and then put the Sioni ring again. But it go again in the vitreous cavity, and the bag is shifted toward the nasal side. So I decided to put the another CTR. Then I try to actually first Sioni ring to come out, but so I try to put the second CTR, so inflate the bag. Now I try to remove the first Sioni ring from the vitreous leading uptake in the vitreous cavity. So by this region, actually I remove it. But after the 10 to 30 minutes, I not find properly the how can remove it. But then I just extend the main port, and then finally I remove it. And then after that, the trailing end of the second CTR is dialed, and do the some vitrectomy again, and again I put the Sioni ring. So in this time, actually Sioni ring actually go in the bag. So after that I find, then suture it with the help of, but the suture was broken. So actually initially I was happy, but the suture was broken. So I decided to take the, took the second suture and try to pass this eyelid. Finally, I actually just pass it from this eyelid. With actually I use the both hand properly, and then go behind the iris with the help of cystitome, and then pass the suture properly. And then suture it. So at this time the bag is become stable. After suturing the eyelid with the scleral pocket. And then after that I put the lens in the bag, but the bag is slightly decentered, and then I rotate the bag, but actually the eyelids were not properly centered, so I put the pilocarpine. So after that I suture this tunnel, and then the post-op period the patient was 6/18, but after the 1 month actually the patient actually complaining the blurring of the vision, and I do the B scan, so the patient actually developed some small amount of the RD. So this patient actually referred to the retina guys. Thank you so much.
So, jury members and judges, I mean, this is one of the most honest surgeons in the world today. Everything that he does, he pleads guilty at the end. So please clap for the one and only Rakesh Saikia.
No sir, I did a very well managed case, because actually you did not find any PCR. The bag always is stable.
Now 7 times in and out.
7, you're wrong. It's not 7 times.
But you have to dare to put the Sioni ring in the 3 or 4 times.
And you have to dare to bear also. So 7 times the CTR goes in, goes out, and yet he persists. And yet it does not occur to him that a vitreous colleague can be brought in,
What would the
can do a vitrectomy, can put in a
Objection,
secondary
Your Honor.
IOL, can put in an iris claw IOL posterior enclavation, can put in a scleral fixated lens, can do a vitrectomy
Objection, Your
instead
Honor.
of all the vitrectomy that the anterior segment does, and that acceptance that ultimately RD occurred. So this is a wonderful teaching video, Dr. Chitra Ramamurthy. You
What?
must never do what you do actually in your OT at Eye Foundation.
What are you talking? What is your problem?
So,
this-
comments.
You come, then you should cut short your complaints also.
Finished.
Meaningless it is.
Cut short.
Yeah, David.
Nee, Professor Chi Sun Fek is there last.
We'll take one photo.
Yes, of course. Yes. Once the comments come.
Yeah, you know, with the large dialysis, the Sione CTR is really tricky to put in. That was a good example. And then, you know, you have to take out your capsule retractors. So, you know, I like using the Ahmed segment. You can both support the capsule during the case, but then you can sort of immediately fixate the bag. And then it's much easier at that point to put in the CTR when you've got the bag fixated. You can leave also capsule retractors in the other quadrants. So, you know, Bob Sione really pioneered this idea of actually not relying just on a CTR, but fixating one of the capsular elements to the sclera. But I think the Ahmed tension segment is just the next generation. It's a good way to go.
That's right.
So, Professor Ko, and then Dr. Mahipal sir.
Yeah, I agree. I think you really needed to get control of that huge dialysis before you tried to put a ring in. And the only way to do it is either put the ring in with a nucleus in place so that it's inflated, or you could try what you did, but I think if it failed on the first effort, I'd go right to an Ahmed segment before I try to put the CTR in 3 more times.
Yes.
I also would wish to say that the number of times that you are attempting, and in case you put one ring and then you put another ring, and then so normally in the such circumstances, if you still want to do a ring, you tie a suture so that you don't lose it. You can pull it out back. So that's what I do. I just tie a steno suture and then try to put it. But I would not have done it in these many, and its segment is better. You have shown classically what not to do.
So, Lana sir, last and the placard.
What he has done, the science has been told, but I appreciate his patience. By with so much of the problems happening, after all the things happening, he did right. Lastly, he could succeed. So I salute the patience is required.
Let us salute his honesty. He even said that it led to RD.
Yeah,
actually,
so that
is a
no. The honesty, another point of negligence is that there are so many times he put in the ring, and he would have expected an RD. He should have been continuously keeping the patient on watch with an indirect ophthalmoscope. You lost the patient. Patient came back to you after a month with an RD. Ideally, I would always tell the patient, if I have this thing, 1 week, 3 weeks, and 6 weeks and 3 months. So I normally follow up the patient with an indirect. And this tear would have been there from very early rather than later.
Okay. I agree with you.
So,
Shall we take?
so the news. He's come prepared for the news.
But the judge has given more. The judge. The judge has given.
May I have your contact, please? Sure. Yeah. No, it's finished.
Dr. Mahipal, Dr. Lahane, I want to say in this age group, he has done probably more number of surgeries.
Are you coming? Really? So much fun last year.
Yeah, of course, we enjoyed you.
I think
we enjoyed you.
Hamza said, oh,
Yeah, it's me. Yeah.
Y'all don't go. There's one important person, Shauto.
So the most important,
Don't take off your thing.
Professor Chi.
एक जज चाहिए.
Professor Chi?
आप बैठ जाओ ना, please.
Yeah. So hand on your heart. Professor, yeah, Dr. Madi, please sit. Dr. Chang? Dr. Chang, please be seated. Yeah, one more. Maypal sir, आप कहाँ जा रहे हैं?
सर आ जाओ ना ऊपर.
The mic.
एक तो आ जाओ सर.
The mic's not on.
लाने सर.
लाने सर आ जाइए ऊपर.
लाने सर, please आ जाओ.
Okay.
लाने सर, please.
Okay, I'll speak the truth, the whole truth, and nothing but the truth.
Okay, thank you.
So my financial disclosures with no relevance. So this was a 68-year-old male with 624 vision due to a posterior polar cataract. And appropriately so, I brought him to the femto laser and did the femto laser treatment and then brought him to the OR. So you can see at the time of surgery, the capsulotomy is complete, well-centered, well-sized. And this is dispersive viscoelastic going under the anterior capsule just to release the anterior cortex, and he suddenly sat up on me. Okay, he had fallen asleep and sat up, and what am I going to do now? So, well, I quickly called my nurses to get vitrectomy out, and with the trocar cannula, I went to the pars planar, and my instrument was so handy that it was just supporting the nucleus, the entire nucleus. I hadn't started surgery really. And with the help of Asinski from the side port, I was going to bring this anteriorly because there was no vitreous there. The whole thing was just dropping. I had dispersive viscoelastic in the anterior chamber that was not aspirated. And now my 23 kH retractor is coming from the pars planar, and I'm cutting the vitreous and then supporting it and bringing the nucleus forwards into the anterior chamber. And you can see this is not a dense cataract. So with a little help with indentation, I was able to bring all that forward, and I was cutting as I went along where appropriate. When I had no nucleus there, I was cutting the vitreous. And you can see I'm doing more cutting there. You can see the probe through this nucleus, which is not very dense. And with the anterior chamber filled with dispersive viscoelastic to protect the endothelium, I'm just creating a little space just under the nucleus and injecting a 3-piece IOL, which I had on standby since this was a PPC. So this is going under the nucleus, I hope. So I'm making sure that it's in the angle now, the haptics in the angle so that it doesn't drop. And I'm using a lens holding forceps that does not mark the optic, and I'm just making sure that the haptic, which is blue in color, which helps me in visualization, is resting on the iris. Now I go in with lowered parameters, all right, and I've changed my sight, my second instrument to just a Sinsky so that I do not actually hit the optic accidentally and mark it. And you can see that this nucleus, it was fragmented already. Femto laser, it comes quite easily with minimal phaco energy required. So at this stage, before I come out, I make sure that the anterior chamber is stabilized, and this is the time I put in triamcinolone acetonide, which has been diluted, so that I can see the vitreous. I couldn't do it at the outstart because the nucleus was in the way anyway. So at this stage, I'm cutting. Of course, this is fast forwarded. I don't do vitrectomy so quickly. I do it really carefully. You can see my infusions coming from the anterior chamber maintainer, so it gives me an extra hand that's free to do necessary maneuvers. And now just with aspiration, having cleared all the vitreous, I clear the cortex from the capsular bag, making sure I don't take a cut, a nip at the anterior capsule. So you can see now I'm moving the haptics slowly into the sulcus, and I have a perfect rhexis from the FAM2, and I'm just doing that optic capture to stabilize everything. So this patient actually did really well after surgery, and this is 4 years out now. He's had no complications. Thank you very much.
Thank you very much, Professor Chi. So quickly we'll go on to the trial. So Professor Chi, the question that I have to ask you is, with a PC tear, why would you do a blind pars plana vitrectomy? That's question number one. The IOL scaffold and then phacoemulsification, then tricort assisted vitrectomy, and aspiration of the cortex, then IOL in the sulcus, then intracameral pilocarpine. But why blind vitrectomy? So cortical matter would be in the vitreous cavity also in such cases, and then obviously you would have had to remove the cortical matter, possibility of the cortical matter falling in, because the vitreous again has been removed to an extent. I would suggest that the best and simplest sequence would be placing the cannula in the pars plana and IOL scaffold over the iris, what you did, and then phacoemulsification with cortical cleanup and removing any fragments in the vitreous cavity that can always follow in. So I feel it's a very rational management, and I hold you guilty, Professor Chi, of management of PCR.
Objection, Your Honor. No, she has gone to the pars plana route to levitate the nucleus up into the anterior chamber. She has not done any vitrectomy there. She's brought the nuclear fragment into the anterior chamber, and then she has placed the IOL scaffold.
Did you do vitrectomy, Professor Chi?
No, she has levitated it.
At the start, I used actually the trocar to support.
Yeah.
Okay, I did not cut first until I had brought the nucleus
up
forwards.
Yeah.
And then I did the vitrectomy.
Then she did the vitrectomy.
So shall we have comments from the jury?
Wonderfully done surgery.
Yeah, I mean, that was an amazing case to, with the patient sitting up, to have the wherewithal to do that. And so maybe the anesthesiologist should be on trial.
So, Professor Maddy?
Yeah, I think she did a fantastic job for such a kind of complication. She managed it well.
Okay.
I think she has done very good job. But okay, she might have slightly changed the sequence of the events what she did, and that might help more. So, but I think she did very good.
Overall management was very good, but the steps were आगे पीछे no man one second. What I would have done in such cases regarding the vitreous loss, the moment she felt it is going into the vitreous, she has levitated, it is fine. But then immediately after that, the vitreous management should have been done before she, of course she used the IOL scaffold, but once you put it, you put the triamcinolone and see where it is before you start managing it, the rest of the case. So I still feel, yeah.
Let Professor Chi answer. Yeah.
So actually, after I had levitated the nucleus anteriorly, and since there was dispersive viscoelastic there, it was a viscoid trap. I then did posterior vitrectomy. As I said, I had sped up everything. Yeah. So actually, I did clear the vitreous to ensure there was nothing there before I put in viscoelastic under the nucleus and then inserted the scaffold.
Correct. So you are not guilty. So we'll God land you. Come here.